this okay, I'm fine with that. We have ISAT and BRAT, two randomized studies. Let's go back to BRAT because there is something I want to show you that 15 years later, there is no difference. And since the endovascularly treated aneurysms have a tendency to regrow and rupture, the differences will be smaller and smaller, and of course in a long run surgery will give more definitive treatment. And you see what we are dealing with, little 1, 2, 3% difference, but as long as p is below 0.005 we are happy. So this is a nice dogma we are having. The other study didn't come to any statistical significance. That was the baroneurological study organized by Spezler. The better evidence, it's not a randomized controlled trial like ISAT or BRAT. You see that it's not at the top of the evidence. At the top of the evidence, there are the meta-analyses. That's the best evidence we can have. There are 370 of them, 17 of them. But all these are like traffic signs. Everyone understands and everyone knows how to follow the traffic signs or a map. It's a general view which has very little to do with a respective patient because we are willing to have personalized medicine and we deal with single patients. So you have a map, you may want to go along this road, but you must get there to recognize what it really is like. You must get there to realize whether 40 miles per hour, which police is willing you to drive, is the proper one. It's very individual. So now let me show you our results over the 10 years where we had both modalities available on a routine basis. This is a period of 2000 until 2010. We had 2 surgeons, 2 endovascular neuroradiologists. We work in the same department, actually. We had 1150 patients. And what we are using is a deliberate policy. First, the aneurysm is treated, and only then the patient is treated if I overdo it. So patient comes in with a subarachnoid hemorrhage, and we treat the aneurysm. We either clip it or coil it, and then we deal with all the other problems. We do not operate on aneurysm during the night, of course. And see the results. Quite a lot of patients, and for unruptured, it's 3.5 and 3.3 morbidity mortality. For ruptured aneurysms, it's set in both techniques. No difference whatsoever. So, as human beings, we have a feeling or tendency to think that the new is better. It's not always true. And if you accept that new, it means endovascular, is better, then you are saying that surgery is obsolete and harmful, which is not true at all. Is there nothing new in aneurysm surgery? There were many innovations because we were pushed to innovate our surgical approaches because there was this other technique. Otherwise, we wouldn't have the reason the ether to survive, to be present, and we still are here with surgeries. This is the ophthalmic aneurysm which is being clipped. It's easy, not easy, but it's fast, very precise, and very effective surgery. This is uncut video of clipping of the ophthalmic artery aneurysm, which you dissect within 5 minutes, and within this time you clip it, you coagulate the aneurysm, and you puncture the aneurysm. See, this is what UIRN's name is calling killing the aneurysm. And you are sure that such an aneurysm will not relapse, will not recanalize. You are done. And if I shall overdo it, you may dismiss the patient on day 3 and never ever see him again, which of course is not true. So this is the effectivity of surgery. Should this intradural surgery for aneurysm last more than half an hour, then something is wrong. And we can approach any vessel in the circulation from one single approach, except for the low vertebral basilar aneurysms. You see all the aneurysms starting with the ACOM, ending with the basal bifurcation. Everything may be dissected free. All these 5 aneurysms were treated from one single small psoriatic craniotomy, and you are able to dissect the aneurysm and clip them at once, which means one risk, one way for complication. Minimal invasivity. I like minimal invasivity in relation not to the approach, but to the aneurysm. Here you see the MCA aneurysm before, after clipping and killing the aneurysm. And all this is the whole cut in the arachnoid, 15, 20 millimeters long. Very limited dissection. The same dissection for such a large MCA aneurysm. And in these aneurysms, we have learned all the techniques. We have learned how to clip the parent artery, how to exclude the aneurysm from the circulation, how to puncture, decompress the aneurysm, reconstruct the vascular tree. We have learned the importance of these tiny, this is the M1, but there are the tiny perforators. We have learned the importance of these. Here is the bypass. We have learned the value of the bypass surgeries in aneurysms. So this is all we have new. We have this ICG, which is an excellent tool in aneurysm. I have said in my AVM lecture that it's not that useful, but in aneurysm surgery, it's extremely useful. You get your control immediately back. You see all those tiny perforators. You will see the bypass, which is over here. It's really excellent tool for whatever you do. Can get forward. Okay, let's get back. One more. What we have else is intra-op MR. This is the intra-op image immediately after clipping the large aneurysm. And you have the DVI regime where you would see any ischemia immediately. You could deal with this ischemia immediately. So another tool. We have CT angio, which you can do whenever you want. So this is excellent. And we have these bypasses, which we can use. So we have lots of new techniques, lots of new maneuvers, which were developed over the past 25, 30 years since the advent of endovascular treatment. But in basics, I do not care if such a basilar tip aneurysm is treated endovascularly or surgically. It doesn't really matter. What matters is that the aneurysm is treated permanently without harm to the patient. That's what it should be. And then let's go for repeated aneurysm treatment. I've shown you that the results are exactly the same for both treatments. The difference suddenly appears in repeated treatment, where we needed to repeat the maneuvers. You see, in 600 surgically treated patients, we needed to redo 20 cases, which is 3.3%. On the other hand, out of 990 endovascularly treated, 136 needed some other treatment, which is 13%. It's statistically highly different. So here is the difference. And the difference remains whatever you take as a subgroup. This is the anterior circulation. Again, 3% versus 12%, significant. Posterior circulation. It's not statistically significant because the numbers are low, 26 versus 128, but still 11 versus 19%. Large and giant aneurysm. Of course, the difference here is very prominent. 1 out of 4 patients treated endovascular with large and giant aneurysm needs some other treatment with all the risks and with all the possible troubles. What were the reasons for retreatment? That's important to analyze. So in surgical group, it was incomplete aneurysm occlusion, of course, in 16 cases. Neurosurgeon's decision when I had the feeling that any clipping or any maneuvering with exposed aneurysm would be hazardous. Those were 6 patients like that. Rupture during craniotomy, 2 cases, and regrowth after initial incomplete occlusion only in 3 cases, which is very low. Here is a case where we needed to redo surgery, the ophthalmic aneurysm at the end of surgery. I was not happy with what I have seen. I didn't see the end of the branches. The aneurysm was not slack completely. So we went immediately to the angio suite. This is 20 minutes after surgery. The aneurysm is filling. So it was treated by coils. I don't know if it would thrombose spontaneously or not, but we did it. So this was one of the surgical cases. What about the endovascular? There are 3 groups why we need to retreat the aneurysm. One is intended partial occlusion at the beginning, which is partly intended. The patient comes in night, we just put some coil in to protect the patient against the bleeding, and then the aneurysm is in the second stage treated permanently. So it was intended partial and incomplete occlusion. Regrowth of the aneurysm, probably the most frequent. After initial total embolizations, which is so-called total or complete embolization, and of course residual filling enlargement. That's the most frequent case. And the third group is complete technical failure, where we were not able to treat the aneurysm in a first stage. So we switched to surgery in majority of cases, but some cases were treated endovascularly for the second stage. Here are some examples. You see the ACOM. First, some coil is put in to prevent the rebleeding. The patient was has 4, and only when the patient improved, we completed the procedure with another coils. Typical regrowth, we all have seen such basilar tip aneurysm and additional coils and stents to deal with the aneurysm permanently. This is 203. The patient is coming in Hunt and has 1. This is his aneurysm in ICA basilar division. The aneurysm ruptured during the procedure. This is the CT, which is not subarachnoid hemorrhage. And now the story starts for many years. 7 procedures, stents, coiling. Finally, we produced this occipital infarction to the patient. The aneurysm is still filling. Now we are in 2016 after 7 procedures with homonymous hemianopia. After one of the procedures, the aneurysm is still filling. And here we are at the end, a year ago in 2020. The patient is doing well, living normal life, but still having her aneurysm patent after that many years. Another case, 2 aneurysms in the VA junction with fenestration. This one ruptured, so we were able to coil it, but that was at the beginning of our endovascular experience. This one we were unable to coil, so this was treated by surgery, and the patient was doing well. Coming back 18 years later with the relapsing aneurysm, of course, there was a discussion if this is the surgically treated one or the endovascularly treated one. It's obvious it was endovascularly treated one, and this is the final procedure to exclude the aneurysm. What about the fate of these aneurysms? We have followed 111 patients, and we have noted 7 bleedings. We could have missed some bleedings. We are unable to follow all the patients since they are coming from all over the country and from abroad, but these 111 were followed because they were from Prague or the vicinity. And you see that the rate of bleeding is 6.3%, which is much higher than the natural course in unruptured aneurysms. So these aneurysms, still being unruptured, are more dangerous than the regular ones. What about the risk of retreatment? Again, we are dealing with something comparable to unruptured aneurysms because there is some time lapse between the bleeding and treatment, and the morbidity mortality rate was 9%. We are having 3% in unruptured aneurysm. So The procedures are more risky, which is logical. And at the end, at the last control we are having in these patients, in 120 patients, if the repeated procedure was endovascular with initial endovascular treatment, in 47% of patients, we still see some aneurysm remnant. If it's surgery followed by endovascular, again, in half of the patients, we see something. If it was endovascular followed by surgery, followed by clipping, we do not see any remnant. The aneurysm is treated permanently. What does it mean? That half of the patients are not fully protected even at the end of the treatment, which in total is some 6% of all endovascularly treated patients. But I must admit that we are unable to follow all our 2,000 patients with aneurysm. So there may be more of them. So to conclude, that the most important for need of retreatment in endovascularly treated patients is initial incomplete occlusion. That the risk factor which is not disputable. But the other risk factors are large aneurysms, 25% of them needed repeated procedure, and of course fusiform and dissecting aneurysm, where nearly all patients needed some additional stents and coils and surgical treatment with exclusion, whatever. Although we can conclude that endovascular treatment carries definite risk of rebleeding, 6% as I've shown you. The technical effectivity, half of repeatedly endovascularly treated patients are not treated and protected sufficiently. So there is a definitive technical superiority of clipping over coiling. Clinically, it's the same, but technically, we are providing the patients with more definite treatment. What about the management? We do not have strict rules. We go case by case. The endovascular people are part of our team. We are meeting each morning on the morning conference. We discuss all the aneurysms. There is not a single aneurysm which wouldn't be seen by both, and where the decision would be done by one only. Of course, neurosurgeons or surgery prevails. There are logistical aspects. Not everybody admits that, but should you have your program for the day prepared and patients prepared for surgery, and suddenly subarachnoid hemorrhage patient comes in, it's much easier to tell the endovascular people do it, even if you would think that the patient would be better treated by surgery. There, of course, are countries with financial aspects, because clipping is by far cheaper. And there are experience aspects, because there are departments where endovascular part is stronger than surgical and vice versa. So there are many aspects which must be taken into account. Our general meaning is that with subarachnoid hemorrhage, we now see more unruptured aneurysms. Actually, we probably dealt with aneurysms too fast, and we do not see that many subarachnoid hemorrhage patients as we did in the past. But the more blood is there in the subarachnoid hemorrhage, the more we go for endo. The worse the WFNS score, the more we go for endo. Whatever you would say, surgery is just another hit to already damaged brain by the bleeding. Of course, the older the patient, the more we go for endo. The more midline aneurysm, the more we go for endovascular treatment. And the more medium-sized aneurysm, they fail, or endovascular treatment fails with large aneurysms, and the same with extremely small aneurysms. We have published these two articles. One of them is coil mainly policy in ACOM aneurysm, and we have 315 patients, and 238 were treated by coil, only 77 by clip. And we published the other article, which is about the MCA aneurysm and its clip first policy. Out of 390 patients, 319 were treated by clip and only 80 by coil. So difference is just the opposite, and this probably shows best our meaning. Actually, MCA aneurysms we do not discuss
anymore. They go directly for surgery. And the next problem,
your time. You have 3 minutes more.
I'm done.
Okay.
I guess this is the last image or the one before last. What's important is that there are many places where surgery is not anymore available. The best example is France. In France, they have that good endovascular treatment that they do not treat aneurysms surgically nearly at all. There is no one who would be able to treat the aneurysm properly. And now you must really be very brave to subject such a case like this one to surgery, because there is always some option behind you. So you must be very, very sure of yourself to clip such a basilar vertebral junction aneurysm. This is old case. I do not know if I would be able to do it now, if I would be brave enough to do it now. I would be able to do it technically, but there is an option which definitely gives good clinical results. Basilar again. So shall we keep the expertise? So in conclusion, it's a quest for balance. It's not a fight. It's not a competition. It's nothing one against the other. It's really question which technique is suitable for particular patient. It really depends on geography, experience, logistics, your philosophy, and individual patient factor. So we really must cooperate. The endovascular people should be the part of the same team. I'm not a friend of hybrid surgeons because they are biased, and usually you cannot be a world champion in table tennis at the same time as in skating. And two brains know more than one brain. So I'm really in favor of specialists, and these specialists should really cooperate. And let me make a little advertisement of the books we have written on cavernomas and brain AVMs. And of course, the next step should be the aneurysms. Thank you for your attention.
Thank you, Dr. Benes. A very nice and interesting presentation. So please check your chat box. Maybe there's some participants answer in your chat box. And we proceed to the second speaker. It is Dr. Ahmad Adam from Indonesia that will present about the topic of ischemic stroke management by endovascular. Please, Dr. Adam, time is yours. Okay, this is the CV of Dr. Adam. He's a neurosurgeon with a vascular and endovascular expertise from University of Pajajaran, Bandung. And he will speak about the stroke management in Indonesia. Okay, Dr. Adam, you have your recording type, right? But you will give some introduction.
Okay. Okay, thank you very much for the committee for inviting me here to speak in second ASN Congress in Surgery. And then also I would like to thanks to Professor Benes, Professor Kato, and our beloved Professor Tesukano for supporting Indonesian nurse surgery and young nurse surgeon, so we can increase our eagerness to treat patients in neurosurgery. Dr. Iwan, I have sent out my talk as recorded as asked by the committee. So we can wait to start the presentation from committee.
Okay, the committee, please, you can start the video recording from Dr. Adam. Hello, Dr. Deki. The committee, you can start the video recording from Dr. Adam. Dr. Deki?
I'm sorry, Dr. Nur Suroto and Dr. Ahmad Adam. Pardon me from the committee, but we don't have any your pre-record program.
No. Oke, dan oke.
Ada mungkin bisa presentasi langsung.
Oke, plan B.
Okay, plan B, no problem. Okay, Dr. Adam, you have 10 minutes of presentation. Okay.
Okay. Is my voice clear, Dr. Iwan?
Yes, it's very clear.
Okay, thank you very much. Today, I would like to share our initial experience in ischemic stroke in Bandung. Actually, we just start in 2017, so it just 5 years our start in endovascular procedure. As we know that the ischemic stroke is higher than the hemorrhage one, and the treatment of the ischemic stroke is all about the time. At the beginning, the admission of RTP is quite superior, but by the IV administration, by the time is will be less than 4.5 hours after stroke onset. And this is the schematic treatment system. We start with the thrombotic agent such as tissue plasmin factor, urokinase, prokinase, and then the role with plasminogen activator, you can create plasminogen to plasmin, and then at last it create fibrin and fibrinogen. As we know that the time is very important in treating the ischemic stroke. So earlier thrombotic treatment was associated with reduced mortality and symptom to intracranial hemorrhage and higher rate of independent ambulation at discharge and discharge to go home following acute ischemic stroke. And with this study, with the mismatch here, we can identify of self-fragile brain tissue, and we can also predict and inform consent to the family member about what will come to the family member that suffer from ischemic stroke. And then there's study, which is the extended time for window for the perfusion. This is from for 4.5 to 9 hours. The use of the artefact between 4.5 to 9 hours after stroke onset, or at that time the patient with stroke symptom resulted in higher percentage of patients with no or minor nerve deficit than the use of placebo. So in patients with evidence of perfusion mismatch or self-fragile brain tissue, IV artefact could improve functional outcome up to 9 hours from the onset. And there is the study of the US Carolina stroke update. It is mentioned that the cumulative evidence from the study saw an overwhelming benefit from the endovascular treatment of acute large artery occlusion, therefore effectively establishing the new standard of care for the management of acute ischemic stroke. And it's more favorable outcome and less mortality. And the study that say that thrombectomy within 8 hours after symptom onset in ischemic stroke is among patients with anterior circulation stroke who could be treated within 8 hours after a symptom onset. Sensitive thrombectomy reduce the severity of post-stroke disability and increase the rate of functional independence. This is comparing mechanical thrombectomy and thrombectomy plus alteplase. It was done in China with a direct empty study clinical trial. So in Chinese patient with acute ischemic stroke from large vessel occlusion, endovascular thrombectomy alone was a non-inferior with regard of functional outcome, within of 20% margin confidence to endovascular thrombectomy proceeded by intravenous alteplase administration within 4.5 hours after the symptom onset. It is concluded in study of mechanical thrombectomy versus thrombectomy with aplasia. So among within the acute large vessel open stroke, mechanical thrombectomy alone compared with combined intravenous thrombolysis plus mechanical thrombectomy failed to demonstrate inferiority regarding preferable functional outcome. However, the wide confidence interval around the effect estimate also do not allow conclusion of inferiority. This is the study which is comparing the mechanical thrombectomy standard versus direct aspiration versus and combined approach. It is stated that standard thrombectomy and direct aspiration did not show significant differences. Current available evidence is not sufficient to draw a conclusion on the best surgical approach. The combined use of standard and aspiration study was associated with high MTC2B or 3 and TC3 recurrence rate, although with a higher risk of 24 hours ACH when compared with direct aspiration. And then this is correlation between time that earlier we treat the patient and more benefit from our treatment to the patient. This is the study, the safety of efficacy of intraarterial uricase after failed, unsuccessful, or incomplete mechanical thrombectomy in anterior circulation large vessel occlusion. Sometimes we could did the exact what we want to the patient. So with this study, in a selected patient with complete or failed mechanical thrombectomy, adjunctive treatment with intraarterial uricase was safe, and further evaluation of this treatment approach seemed to be warranted. So in conclusion, evaluation of perfusion mismatch might extend therapeutic time without thrombolysis. And in the state of the art of clinical application, mechanical thrombectomy is keep evolving. And now combination of intravenous artiplacer to mechanical thrombectomy minus than mechanical thrombectomy alone. So intraarterial thrombosis might become failed strategy after unsuccessful mechanical perfusion. And this is the example of our initial case. This is 55-year female with vital hemiplegic. And we're using aspiration. There's the obstruction in the ICA. And then we do the aspiration. And this after the aspiration. And this is the thrombus that we can aspirate. And this is the last picture. And the second case, 60 years old male with left hemisphere. The onset is 7 hours. We're using Eric thrombectomy. There's obstruction on the MRMT branches on the left side. And there's the thrombus that we treat. This is the balloon and Eric. This is the final picture. And the third case is the 72 years old female with leakage on the left side, 70. There's a obstruction on the empty branches. Now, yes, the perfusion, good perfusion. And this is the thrombus, then we do the perfusion study. So there is a good perfusion in this patient. And the last patient is a little bit late, 10 hours after the onset, because of confusion and left hemiplegic. Just distal IC obstruction. And we do the aspiration to this patient. And this is the final picture. And this is thrombus that we can aspirate from this patient. Okay, that's all. Thank you, Dr. Iwan, for time. Thank you.
Okay, thank you, Dr. Adam. Very clear presentation and you video set on time. So please to the speaker, check your chat box. Maybe because there are some participants ask some question directly to you, but we can discuss it in the discussion session at the end of this session. We will move to next speaker, Dr. Krishna Prihastomo. Dr. Krishna Prihastomo, please the committee show his CV. So Dr. Krishna Prihastomo is from the Dr. Karyadi General Hospital in Semarang, Central Java, Indonesia. And he will give a presentation about the minimally invasive intracerebral hematoma evacuation using endoscopic assistance with available resource. And Dr. Krishna, you will present your presentation lively, right?
Yes, yes. I would like to present lively, yes.
Okay. The time is yours.
Yeah, okay. Thank you, Dr. Nur Setiawan Suroto, for the time. Please allow me to share my screen. Okay, I hope you can clearly see my slide. And also my voice, I hope is also clear. So, okay, thank you for the committee for giving me opportunity to this Asian Congress of Neurosurgical Surgeon for presenting our kind of mini research in our center about minimally invasive intracerebral hematoma evacuations using endoscopic assistance with available resource. So my name is Krishna Sanedri Prihastomo. I currently work as a staff as a neurosurgeon in Dr. Karyadi Hospital in Semarang City, Central Java. So as we know that the hemorrhagic stroke account for about 13% among US populations, where in Indonesia for about 18.5% in Indonesian populations. And of the disease, it really gives very great impact for someone's quality of life because it can increase the disability adjusted life year expectancy, which is some years that somebody lost because of a specific disease, and it's also giving increase of hospital costs, the length of stay, and also giving the mortality rate for about 23.3%. And as we know that there are 5 common locations of hemorrhagic stroke caused by hypertensive. The most common is the putaminal hemorrhage for about 40 to 50%, and followed by lobar and thalamic, and then the rest were pontine and cerebellar hemorrhage. And the management of the stroke hemorrhage nowadays, the medical management still, take a very first line in the management of stroke hemorrhagic, but there are some surgical options for this specific disease, including inserting the external ventricular drainage plus monitoring the intracranial pressures, doing the craniotomy and evacuate the clots, doing the decompressive craniectomy for massive brain edema with or without evacuation of the clot, and also evacuate the clot by minimal invasive measurements such as endoscope, stereotactic, tube, etc. And we also need to remember the stitch and stitch to trial, which of course giving us information that there is no beneficial or favorable outcome if we compare the medical treatment compared to the early surgical procedures. And the first trial of endoscopic intracerebral hemorrhagic surgery was done by Ludwig Auer in 1989 and published in the Journal of Neurosurgery. The remarkable remarks that we can extract from this journal is that this journal, including 100 patients with 30% lower mortality rate if they compare to the medical therapy, and 40% better outcome. But of course, this study have limitations, which were there are no comatose patients included to this study, and there are also no thalamic lesions included to this study. So the randomization is kind of questionable. But of course, this is very hard to decide whether the comatose of the thalamic lesion should do the minimal invasive surgery. So why we should consider the endoscope? So first, that minimal invasive is not just about the size. It's also about the minimal exposure of the patients to the anesthesia agent, minimal time of surgery, etc., which at the end it giving the patients beneficial above all. So the endoscope giving us smaller incisions, those it can give faster closing the sutures, and then of course faster wound healing. And then endoscope also only use smaller craniotomy if we compare with the standard craniotomy one. And this also can avoid overexposure of the normal surrounding brain tissue. And the scope itself can give us better visualizations. You can see on the right graphs there that if you use microscope, we only have a visual field. Our eyes can only see the operating field on this yellow area. But if we look inside, so we move our eyes, the scope inside the lesions, we can see this larger, better visualizations. And even we can see almost 360 degrees if we inserting the angled endoscope. And also there are several established current trial of minimal invasive surgery in ICH, in this hemorrhagic stroke. The ICs, the MISTI, SCUBA, ENRICH trial, INVEST-MIND, and most of them were focusing on giving patient with surgical procedure with minimal invasive using stereotactic endoscope, etc. So our study here, our mini research here will retrospectively obtain the data from 2018 to 2021 in our center, in single center. We will explain about a bit about the surgical technique, the usage of the available resource in our hospital, and the result from this past 3 years. The surgical technique itself will include preparation, incision, craniotomy, evacuation, and the closure. The preparation itself, we use the standard craniotomy instruments, and we use the available resource. What we mean by the available resource is that the resource that we can use and can utilize it, of course, not exclusively by ourselves, but also can be used by other department. The first one is the 0 degree 4 millimeters rigid telescope, the Hopkins telescope, which length for about 18 centimeters. This telescope is usually used by the skull-base surgeon for pituitary adenoma, also used by ENT surgeons. So if you are a neurosurgeon in a remote area that have ENT surgeon that doing the sinus surgery, of course, this endoscope should be available. The second one, we use forceps for extracting the clots, and this is also the special working channel. We personally made a working channel from syringe, the 3cc syringe, and some of the patients using half cut of pediatric rectal tube. And we also use the gelatin sponge for hemostatic agent. This one is the telescope, the endoscope we commonly seen, and the forceps. Okay, so this is the example of working channel that ideally used in the endoscopic ICH surgery. The stainless steel one, the dilated working channel, the neuroport, the fuse light, etc. But in our center, we do not have it all, and sorry, and it is not available, and it really give us a high cost if we want to make it available in our center. Okay, I cannot. Okay, so to overcome that, we personally made our working channel by using the 3cc syringe. So on the very left figure, you can see the 3cc syringe. We cut it on the distal tip, so you can see we can have the two holes, the proximal and the distal one, for inserting the instruments. We also, in some patients, one or two patients, we also use the pediatric rectal tube. The advantage of the syringe we use that this is rigid, and they have also the transparent lumen, so we can barely see the surrounding brain tissue. So if there's any damage or any surrounding bleed, active bleeding, we can anticipate it. And if we cut it transversally, we can see that we can only insert two instruments inside the working channel, the telescope and the instrument, and we can move the instrument like a twisted movement inside the instrument. Okay, so the incision site is the highest point of the clots, and we need to take into account that we need to take our most comfortable positions, and the monitor of the endoscope must be perpendicular or 90-degree to the surgeon's eyes. It will allow us to have a steady still hand positions, because otherwise if the monitor is not perpendicular to our eyes, for instance, it's the image is going on the right side, so our hand will tend to move toward the monitor, and which is very dangerous for something going inside the brain. Also, another tips for this endoscopic surgery, that we can also see the anesthesia machine, the vital sign, and also the image. The incisions of the patients we have an option with linear incisions, curvilinear, and lazy S. Well, those three options, we don't have any specific considerations, but the lazy S giving us more wider if we use the skin retractor compared to the linear incisions. The entry side of the working channel, we usually use the shortest trajectory, the distance between the surface and the clot. And if it's too the distance is too deep, we usually do in the cocker point. We only use one burr hole and 3 centimeters in diameter for the craniotomy. And then this is the example of the incisions. This is the cocker point we use on the left side, because we need to avoid the eloquent area on the left hemisphere. This is another example of linear incisions. We only use for approximately 3 centimeters, as well as the craniotomy below. And this is example of on the temporal side instead of the cocker one, because the distance of the surface to the clot is shortest in the temporal trajectory. And the key step of these surgical procedures, well, actually there is no special key step for these procedures. We do the minimal corticotomy just for introducing the working channel. We only do the suctions and evacuate the clot by forceps. So suck and forceps, suck and forceps. There is no bipolar coagulation, or if we desperately need coagulation, we only use the minimal bipolar coagulations. And we have to take into our attention that there is no need to take out all the hematoma once the brain is already relaxed, then it is time to think that we need to stop. The working channels is also dynamic, so we can get it inside and outside according to the clots, and then we can also pull out it all and then inserting the scope without the working channel. Hemostasis using gelatin sponge and irrigations, and of course we need to do care about the surrounding healthy tissues. This is the examples of the video we have. Example of lobar hematoma, the temporoparietal regions. This is female 44 years old. Okay, this is we already introduced the working channel. The scope is going inside. You can see here, you can notice that the surrounding white brain tissue, the normal brain tissue, is barely seen on this transparent lumen. And then we sucking the clot out, and sometimes we can use the forceps if the clot is hard enough to be sucked. And of course, we need to take it out very carefully. And what is the advantage of this technique is that our eyes is directly going inside the lesion. So we can see here which side is already free from clot, which side has the remnant clot here. And sometimes in this narrow locations, narrow operating field, using the working channels is helping. We can suck doing the evacuations of the clot on the almost unvisualized on the barely naked eyes. So using the endoscope, the visualization is almost perfect here. Okay, so here you can barely see that the brain parenchyma is already relaxed. There is some space between the dura mater and the brain tissue. We inserting the gelatin sponge for managing the hemostasis there. We just leave it there and irrigate for some times with a warm normal saline. Okay. Yeah. Okay. Then we this is the left below figure is the post-operative CT scan. Here we can still see some tiny remnant of the clot, but of course this is not to be worried, because sometimes there is no problem if we not taking all the clot. So our single center result, in these 3 years we already done in 24 patients. Most of them were male. The age mean was 54.8 years old. The Glasgow Coma Scale pre-op range from 6 to 15, with the median is 9. Also, we divide into GCS below 8 and GCS above 8. We operate on the patient GCS below 8 for about 6 patients, or a quarter of it, 25%. The result, the locations of the hematoma, mostly in putaminal, about 72%. And the second one is the frontal lobar hematoma. The rest one is the parietal, temporal, and some thalamus subcortical. The pre-op GCS distribution, as you can see on the very right top graphs, and the comparative stack bar chart on GCS distribution pre and post-operative, you can see on the left. There are some patients died. So from 24 patients we operate, 10 were have unfavorable outcome or died. So above all, 10 was dead, and most of them were having good recovery and mild disability. We have a curiosity of the very high amount. Of course, this is not 50%, but 10 is high if we compare with the total 24 patients. Of this very high amount of death, we have curiosity whether the preoperative clinical condition of the patient is already bad or not. So first we cut the patients, we divide the patient by the GCS 8. We see that the GCS above 8 still have a large amount of death patients. But if we cut the GCS on the 10 point, so we can see that the patients that have GCS more than 10, only one have death, and the rest were mild disability and good recovery. So the GCS below 10, there are 9 patients have unfavorable outcome. So this is a big question for us, but we need to do more research about this, about how or in what point in what clinical condition patients should do the endoscopic surgery. This is the durations of surgery, all surgery. The mean was for about 1 hour and a half minutes, 1 hour and 30 minutes, 96 minutes, with no differences if we divide into the locations. We do also some post-operative imaging. This is some very nice evacuations we have with some favorable outcome of the patients here. This is the left putaminal hemorrhage. We evacuated from the Cocker point frontal. And then this is the right large putaminal hemorrhage here. Because this is the right side, we have, you can see here, the corticotomy is on the temporoparietal regions here. There are some remnant of the clot. And also we notice that there is infarctions on the internal capsule there. And this is the one that we showed the video before. Okay, so the future directions of this study is that we need to know that what kind of the patients can do the endoscopic ICH evacuations. We also need to know the cutoff point of the GCS. Is this really favorable for the patients? Is minimal invasive, is suitable for stroke patients, etc. And of course, more supporting device we need in our center. And I think multi-center study is needed to, of course, establish a new guideline if needed on endoscopic ICH surgery. I think that was my presentation, Dr. Nur Setiawan. I give it the time back to you again. Thank you very much for your attention. Advice and criticism is always welcome. Thank you very much.
Thank you, Dr. Krishna. Very interesting presentation about your experience. So now we will move to next speaker, the last speaker, I think, Dr. Harsan. So I would ask the committee, is it Dr. Hasan already joined us?
I'm sorry, Dr. Nur Setiawan. Dr. Hasan is not joined with us. Maybe we can move to the discussion.
Okay, so while waiting maybe for 5 minutes, but we have still time to discussion until 4 p.m. at Lombok time, right?
Yes.
Okay. Okay. Please, participant, if you have any question, you can ask directly, or you can chat. You can type your question via the chat box. Okay, I don't see any question yet. So maybe is all speakers still join with us here? Professor Benes, are you still here? Okay. Okay, maybe my question for Dr. Adam. Dr. Adam, how is your experience of doing thrombectomy in your center? Because mostly the patient came to the hospital after passing the golden period, right? So how you manage for the patient, or I mean the patient selection that is a best candidate for thrombectomy patient?
Well, actually, in treating the ischemic stroke patient, because we have we have stroke team. So there are 4 neurology and 1 radiology and me as a neurosurgeon. So the criteria was done by neurology, and then they discussed in the WhatsApp group what should we do, and then we came together and give informed consent to the patient. And of course, we also, but here what I'm talking about is not in our government hospital. We are doing in the private hospital. Then after we have what we are going to do, and then we tell the patient about the financial and then insurance, and if the patient is okay, then we proceed to the patient as early as possible.
Do you use CT scan based or use also MRI for
Yes,
stroke
both.
patients?
Yes, we are doing both. We are doing both. Yes.
Okay.
But
Thank
in
you, Dr. Adam.
our government hospital, we cannot do this because the patient came to our government hospital is too late. So our neurology also just try to put the IVRT plus only. Okay, thank you, Dr. Iwan.
Okay, thank you. So still there's no question from the audience. Okay, maybe for Dr. Krishna, I have one question for you. How you manage the patient selection for the best candidate for the endoscopic technique, and also how about the time? Is it after 24 hours still possible to do the endoscopic evacuation?
Okay, thank you, Dr. Nurstiawan, for the question. So the first is the patient's eligibility. So what kind of the patients I included to this study? So firstly, of course, the hypertensive stroke, I only operate via endoscopically in the hypertensive stroke. So I don't need, there is a place for endoscopic or minimal invasive in the intracerebral hematoma caused by MCA aneurysm or caused by AVM. So all of the patients were caused by the hypertensive. So either putaminal or lobar. Some were thalamic, but of course the thalamic is not giving us a very good outcome. And we have to make sure that there is no vascular abnormality, because it's kind of suicide if we do very narrow visual surgical field for that kind of disease. And for our limited study, we only do the patients, we only do mostly we do on the patient with preoperative GCS more than 8. Only one patient with GCS 6, but that of course not giving us a very good outcome. So I think the cutoff point of whether the patient should do the endoscopic surgery of doing the craniectomy decompressions, we should of course do the further study. But in our experience, we do almost good clinical condition of the patients. And the second one, I'm sorry, your second question, Dr. Nur Setiawan?
Is there any time consideration?
Oh, okay, time consideration. So most of the patients were consulted from neurology department, so we don't have our personal. I mean, the patients going directly come to us, no. But of course, if we think that the clot have mass effect, so we do it immediately. So we don't consider any time of surgery. Of course, if the clot is already absorbed, found by the imaging pre-op, of course we don't do that. So in acute phase, yes, we do the surgery. We do not consider any time before the surgery.
Okay, very interesting.
Yeah.
Thank you very much, Dr.
Thank you,
Krishna.
Dr. Mustiawan.
Okay, okay. Is there any question from the audience? You can ask all the speakers directly. Unfortunately, Professor Benes is not with us anymore. So, okay. Okay, I think we can close this session. Again, I would like to give my very good appreciation for all speakers, Professor Benes, Dr. Adam, Dr. Krishna, and to all the audience. I saw Professor Kato and Dr. Sejawidi here also. Thank you very much for joining with us. I hope that we can have a meeting in the next future directly, and I hope that all of you in a good and safe condition. Thank you very much.
Dr. Nur Setiawan.
Okay.
Dr. Harsan is ongoing process to join with us.
Okay.
Maybe we can wait for 3 or 5 minutes.
Okay, we still have time, right, until 12 p.m. Okay, we will wait for him.
Yeah. Thank you.
Dr. Nur Setiawan, maybe
Okay.
together with waiting Dr. Harsan to join us, I have some direct question which is message directly to me. Maybe
Okay,
I can. Yes,
okay,
I
please.
can. Yes, just of course until Dr. Harsan join us. The first is the evacuations done in emergency operating chamber or the elective one? The second one, is there a mean time between patients come and the surgery? The third one, is there a criteria how many volume of the hemorrhage for this minimally invasive surgery? So my answer is that the first one, we have integrated emergency and elective operating room. So all of the patients were done in emergency setting. So it's as fast as possible because we don't separate our OR. So it's not a very big problem for us. So the point is that we have that endoscopic tower in our emergency OR. The second one, we have the data of the mean time the patients come and the surgery, but I'm not showing you yet, and it's not available yet. But of course, we do it as soon as possible as the patients consulted to us. And the third one, how many volume of the hemorrhage for this MIS endoscopic surgery? So any of the volume that cause the mass effect for minimum 30 cc's and giving mass effect. Okay, that's all, Dr. Nur Setiawan.
Okay, thank you, Dr. Krishna. Okay, Dr. Harsan, are you already here? Dr. Harsan? Okay, we wait for another 1 minute maybe.
Dr. Harsan is joined, Doctor.
Okay, okay, luckily we have still time. So we will move to the last speaker, Dr. Harsan from Siloam, Jakarta. So the committee, please show the Dr. Harsan's CV. Okay. Okay, here Dr. Harsan is a neurosurgeon from Neuroscience Center Siloam Hospital, Karawaci, Indonesia. He's one of the founder of endovascular neurosurgery in Indonesia, I think. So, Dr. Harsan, if you already with us, please, the time is yours. You have 10 minutes of presentation. Thank you.
Thank you, Dr. Iwan. Is my sound can be here?
Yes, your sound is very clear. You can show us your presentation also.
Yeah. Wait, I'm opening my presentation. Sorry, is a little bit in a hurry. Okay. Okay. Yeah. Okay, I will start to slide share. Okay, my Zoom screen share. Okay, can you see my presentation?
Yes, very clear. You have 10
Okay.
minutes.
Sorry for waiting. Thank you, Mr. Iwan. Thank you, ladies and gentlemen. Thank you for having me to present or sharing some of my cases. So today I will share some of my experience in doing coiling aneurysm from simple to some with adjuvant. So I will start with the important paper that make the coiling, we can say same usefulness in treating aneurysm comparing with the clipping. So that was ISAT that was actually published since 2005. As you can see here by this ISAT, it showed that it has some advantage that the coiling has less number of morbidity and also seizure, but the negative if the coiling has some more number of rebleeding in the later case. But I believe with some new tools and equipment, this rebleeding number can be reduced. Another important thing on the paper is that the coiling is accepted as the guideline of the treatment with some indication, which is the treatment of choice according to the patient condition. That is, if the patient old, in poor grade, or especially aneurysm in the posterior fossa. In some paper also, we can see that the number of coiling is increased by the year. One paper followed from 97 to 2000, and the other paper followed from 2002 until 2016, which shows that the number of coiling is increased because the patient more and more happy to have their aneurysm treated by minimal invasive without opening their head for surgery. And the latest paper in 2019 say it is about 60 to 70% aneurysm was treated by endovascular. So now I will start some of my thought in doing coiling, which is, as you know, we have to do preparation before doing coiling. it is include, we study the clinical condition of the patient, and also I think the most important thing, we know the morphologic or angioarchitecture of the aneurysm that we're going to treat. And after that, we know what is the plan, what will we do. And including in the planning is what is the equipment that we need to prepare to do the treatment. So to study the angioarchitecture of an aneurysm or vascular anomaly, we maybe start with the 3D CT angio. As we know now, the 3D CT is available in many hospitals in Indonesia also. And if there is any doubt or we need any confirmation, we can do DSA, and the other also 3D DSA. With all the images that we have, we will do we will do reconstruction, and also from this reconstruction we know what is the best or the possible projection to do the procedures. This is one of the example that a case that we have about 2 months ago. The patient come with bleeding. From this bleeding, we know that this is specific for aneurysm. But from 3D CTA, the aneurysm was not very clear. Also at the time, the surgeon asking to do angiography because they want to know what is the exact shape of the aneurysm, also the location of the neck and the direction of the dome. So we do DSA, and as you can see here, the aneurysm actually not on the ACOM, but on the junction between A1 and A2, and actually it is secular. And as shown here, I can put a coil to do framing, and then filling, and then continue. And this is the final that finally we can do coiling for this aneurysm, which on the 3D CTA, not very clear. Also from 3D CTA, looks like it is a wide neck aneurysm on the ACOM, but by angiography, we can clearly see what is the shape of the aneurysm. And in this case, we do coiling for this patient. So now I want to share about safety in doing coiling, especially for small aneurysm, because standard aneurysm 4 to 5 millimeter, and then with narrow neck, it's we can see simple. But aneurysm less than 3 millimeter is difficult because it has a high risk of perforation. So some of the tip is we enter the aneurysm not with the microcatheter and microwire, but only by microcatheter. Also, we can do this, the shaping of the microcatheter, and do not remember to remove the slack, because if we have the slack on the microcatheter, the microcatheter or microwire can puncture the dome of the aneurysm. And the target to do safety coiling is to avoid rupture. I mean, to avoid rupture during we do coiling or before we do coiling. Another thing, if after that we have framing, if we insert the coil to the aneurysm, there is two problems that can be happen. Number one, if the microcatheter backs up or the coil prolapse. If the microcatheter back up, it means that the coil is maybe too big for the aneurysm, or maybe the coil if is too hard, so the microcatheter will back up from the neck of the aneurysm. Also, if the coils prolapse to the parent artery, maybe this is due to the neck is wide. So in this case, we have to change the design of the coil at the more firm, or if we need, we have to do some adjuvant like doing balloon remodeling technique. This is one of the sample. This aneurysm is about 2 millimeters. So I'm, as you can see here, I put the tip of the microcatheter just on the neck of the aneurysm, and then slowly I insert the coil from around the neck of the aneurysm. This is the final condition, and on the right side is a 1 year follow-up of this aneurysm. This is another simple aneurysm on the Vascular tab. In this case, the neck is good, so the coil do not prolapse to the parent artery. I can put the coil, and then before I finish, I do checking by rotation without contrast, just to see the position of the coil. And this is the before and after coiling of the aneurysm.
Dr. Hasan, you have 2 minutes left.
Okay. So this is another picture. I just want to see that with how we need a specific projection to see to show the neck and the position. This is another ACOM aneurysm. We have to find a good projection to see the neck of the aneurysm and the surrounding vessel. So this is the definition of the wide neck aneurysm. In wide neck aneurysm, as I said, that there is a risk of the coil protrusion to the parent artery, and because of this condition, it is difficult for us to have tight packing. For wide neck aneurysm, we have several options, that is put the stent or have balloon assisted, and another choice that I do in many cases by double microcatheter. So this is the comparison between stent assisted and balloon assisted coiling. This is some paper that have the experience in doing a double microcatheter that was started in 1998 by Baxter in USA. And then it is developed very much in Korea. The advantage of the double microcatheter is because we do not using stent, so it is good in the rupture case that we do not need antiplatelet drug, and then it is safe, and also if we saying about the price, it is cheaper than balloon assisted coiling. So this is a stent assisted coiling. I share one of my cases. This is I use stent and coil. This is before AP and lateral view. This is when I do coiling. After I'm opening the stent, I put the coil in the aneurysm. This is the angiography after procedures. This is AP, and this is lateral view. Another sample here is when I do double microcatheter technique for aneurysm on the PCOM on the left side. This is the first coil, and this is the second coil. This is the third coil, and this is the fourth coil. Because the coil can be mixed each other, the coil can stay inside the aneurysm even the neck is wide. And this is the final DSA for that patient. This is pre and after coiling. This is another sample of PCOM, also with wide neck. And this is I show the specific projection to see clearly the relationship between parent artery and the aneurysm and the neck of the aneurysm. So in conclusion, there are many techniques to do coiling of an aneurysm, and understanding the anatomy and architecture, also tools and equipment. I mean, how the tools and equipment can help us to do coiling in a specific situation. It is important. And all of this is a key to do safe coiling. Thank you. I would like to extend also my deepest condolence for the passing of Professor Ted Kano, which is one of my teacher. I have a chance to stay with Professor Kano in 1998 to 1999. Okay, thank you, Dr. Iwan.
Okay, thank you, Dr. Harsan, for the nice presentation. Because of we have overtime from the schedule, there's no question for Dr. Harsan. So I will give back the session to Kapite. Once again, thank you very much for the audience for joining us. Thank you.
Thank you, Dr. Nur Dewan Suroto, and all speaker and all participants. Before we are going to the next session, the vascular session. Maybe could we take a picture, please? And then all the participants, please show on the camera. Okay. Once again, all the participants, please kindly to switch on the camera. In my command, we will take a picture. 1, 2, 3. Okay, once again, for the next slide. 1, 2, 3. Yeah, okay. Thank you.
Thank you for the committee.
Now we could move to the second vascular session. Maybe we take a break for 3 minutes. Good afternoon, ladies and gentlemen, dear professor, doctor, invited guests, and all participants. We will continue our second session of Vascular with the moderator, Dr. Krishna Sanyadi Prihastomo, neurosurgeon. I will read the CV. He has a neurosurgeon, staff of the Department of Surgery, Dr. Karyadi Hospital Semarang, Indonesia. Education, 2013 to 2018, Department of Neurosurgery, Erlangga University, Dr. Sutomo General Hospital, Surabaya, Indonesia. 2005 until 2012, Faculty of Medicine, Diponegoro University, Semarang. Now, the additional education is 2012 until 2013, Emergency Department, Medical Doctor, Kusumo Hospital, Semarang. 2012 to 2013, Emergency and Intensive Care Medical Doctor, Ken Saras Hospital, Semarang. And 2018, until present, staff of Department of Neurosurgery, Dr. Karyadi General Hospital, Semarang, Indonesia. For Dr. Krishna Sanyadi Prihastomo, the time is yours.
Yes, thank you for the committee. So we continue to our second vascular satellite symposiums. So we have for approximately 1.5 hours for these sessions with 4 our respective speaker. So we are, of course, directly going to the first speaker. Okay, the first speaker will be Dr. Satyo Widi Nugroho from Jakarta, Indonesia. He will talk about intracranial aneurysm, recent and future neurosurgical services in Indonesia. So he is now currently the staff of Cipto Mangunkusumo National Hospital in Jakarta, and he is now also the chairman of the Neurosurgical Collegium, Indonesian Neurosurgical Collegium. So, Dr. Satyo Widi, you have 15 minutes for your presentation. So the time is yours now. Dr. Satyo Widi, are you already joining?
Okay, I cannot unmute myself. Yeah, thank you.
Okay. Yes. Okay, so this now your voice is
Yes.
Perfect, clear.
Yes. Okay, thank you. Okay, I have 15 minutes. I will speak fast. There is 25 slides that talking about aneurysm. I'm not talking about technique, but mostly some regulation. Just a moment. I will share my slide. Yes, thank you, Dr. Krishna, and thank you all. Good evening, all the audience, ladies and gentlemen. My topic is about intracranial aneurysms, recent and future neurosurgical services in Indonesia. Yeah, I hope it will give some nuances in our situation today. I believe that many of us has already performed this kind of difficult cases to be solved in Indonesia, and I will give some description about this. I think I will pass this one. It's not so important. The original words of aneurysm from Greeks, ana and euros, and become aneurysms. And Galen is the first to be put in the lexicons medical. And we know that in the side of prevalence and incidence in international data, I think we know that aneurysm is about 4% of population of the prevalence based on autopsy and radiologic findings, and incidence yearly about spread from 3.9 to 19.4 cases every 100,000 populations. So the average is about 10.5 cases every 100,000 population. In Indonesia, there is no data, of course, we know. We hope in the near future, our government insurance will give us the data, how many is the cases or incidents in Indonesia. But if we refer to the incidence of, I'm sorry, I have to put this. yes, like this. Incidence of 10 every 100,000 populations means that we should have about 20,000, 27,000 cases a year, a huge number. Should be a huge number that we should solve in Indonesia. Only we don't have data. Many of the patients died maybe before having treatment, or it is underdiagnosed, or whatever else. So I call it a very small number. The data is very scattered. We always present it in this kind of meeting, national meeting, but we never have the real data, how many of the aneurysms cases in Indonesia yearly. And yeah, the number is small that is treated by surgical endovascular. I think this is history. Again, I will not read every of it. We know that the development is from started by carotid ligation, by tying with the thread, or by clipping with undetachable clip, and then followed by wrapping. Professor Norman Dodd, I think there is a manuscript about it. This is the picture of wrapping, and then continues by clipping. We know some of it. I think we met some of it. Professor Yasar Kun, Professor Sukita is one of the most prominent surgeon and designer of very, very good clip in the world that is used until now. And also bypass now become very popular because it is considered to be the future of surgical technique in treating aneurysm that cannot solve by coiling or endovascular treatment or conventional neurosurgery. And this is also the evolution of surgery. I think the red block I have put it to be easier to be learned. First started by occlusion, wrapping, clipping, and then clipping designs, and then start by coiling embolization, and then development of the flow diverter coil, and now the new device of endovascular is developed very fast. The new one is web, flow diverter, stent, pulse rider, and so on. And I think it will come another device that we believe in the future will solve so many problems of aneurysms in the society. But of course, in between there are also ECIC bypass as STA, MCI, low flow bypass, and high flow bypasses as well. Here's the situation in Indonesia right now. The dot blue is considered to be, I put this to be the regions that has been serviced by a neurosurgeon. We grow fast enough right now. Every province, almost every province have already had neurosurgeons. Only 3, if I'm not mistaken, the Southeast Sulawesi, and then West Papua, and I think West Papua has already been having, but I am not sure the data. I have to make it clear. But we know that in my list, the data of the neurosurgeon that will be granted by fellowship certification or consultant certification, there are only some few provinces that already have the neurovascular surgeons from North Sumatra, Riau, and mostly in Java, Bali, and also in Makassar. South Sulawesi has already have a neurovascular surgeon. We have still so many regions that don't have that. We hope in the near future they will learn formally by fellowship program. This is what we usually do with the aneurysm. I think this kind of complex aneurysms usually treated by surgery right now in our department. It is not coiled, difficult to be coiled, so we do the doing by clipping, of course. This is in emergency case, so the subarachnoid hemorrhage is still prominent. We do temporary clip in the left A1, and then in the right A1 clipping. Usually, I usually clip only these two, while some other surgeon clip also the A2 branch for a temporary clip. But for me, two A1 is enough for reducing the flow of the aneurysm. That complex aneurysm can be during the surgery. We can see the size and the shape of the aneurysm, and we consider inside to how to clip the aneurysm. It seemed to be a very small remnant here, but we control it by intracranial Doppler, and we don't see any flow, so we just stay it and then didn't add any other clip and at that place. So we can see here, and after that, we take out the temporary clip and put. I will make it fast. The Doppler, and then check every part of the aneurysm and all the branches of the parent and artery. And then always, this is 8 months after surgery, there is no remnants after we control with digital subtraction angiography. And usually a year later, we perform another digital subtraction angiography for controlling the result of the surgery. And this is also, of course, if the technique that we usually did in another of surgery, we do coiling, and also in the right side with flow diverter. You can see here this direct simple A1 ACOM aneurysm. We do it with coiling. I think everybody have done it in some of the neurosurgical center that have this facility. They can do it fast, and they can do it perfectly. And then also this one is this giant's ICA aneurysm intracavernous. It's very big. Right now, there is no place to do it with surgery, or so we do. We put flow diverter. I think everybody has explained about this. And formally, when I learned this, I joined the surgery that we do entrapment of the very big. Yeah, so we just put it, and the result is very good on this very small filling of the aneurysm, and later on it's gone after a while. Okay. This is what we usually do. What is our situation in Indonesia right now? I put it, maybe I hope it is not too hard for us, that cerebral aneurysm in Indonesia. When I search in Google or PubMed or whatever scientific search, I don't find any of us have already put it on the peer reviewed journal. I think it is a challenge for us. It is only some popular documentation that tell us in the Google, compare with what we have in Korea. My friend Korea, they have so many data that talk about their scientific result or whatever national data to be put in the even in the Google or whatever scientific peer review. Some of us, of course, have. I found it. Some Dr. Marjono have put a case when he was in Helsinki. I think it is together with Professor Juha, but there is no real data or real scientific review that to be put in the scientific journal. Of course, we have a problem with not enough insurance finding. This is in our institution. Aneurysm is only funded about 5,000 US dollar, where we put coiling and also clipping only 5,000, while the procedure usually needs about 8,000 US dollars. And the future, I think our challenge will be the experts, funding, facility, and national database, of course. And we have, you know that, and expert, we have now our friend, our college neurologist and neuroradiologist that works also in this field. They do diagnosis and treatment, and there are more and more neurologists and neurointerventionists are treating this kind of problem with neurointerventional procedure. I think we will need a lot of experts, of course, but also we have to consider them to be our good competitors. So we fairly must be able to treat this problem side by side with them. Okay. What about the neurosurgeon aspect? Of course, we do diagnostic, we do treatment, and we can see here that there are small numbers, as I have mentioned before, become vascular neurosurgeon and who treat aneurysm by surgery and endovascular. We have advantage because we can do both of these techniques, surgery and endovascular. So many of neurologists, general neurologists send the patient to us because they know that we can treat if there is a problem when endovascular procedure can be done perfectly with this problem. We can change to the surgery, or we can cope with the complication if something happened during the procedure. But also in the field, we can see that some of our friends are still do the case with substandard management. This is a sample of a case that come to our institution, M1 aneurysm clips, but the family or the patient is not to be advised to be followed up. They say that it doesn't have to be followed up. So it is a problem for us. The patient come with another bleeding 4 years after the first clipping, and there is a growth of the aneurysm. We can see here. The clip is here in the site of the aneurysm. I think it is slips or because of the growth of the aneurysm. So we try to solve it with, this is a very bad condition of the patient, with surgery. We clip in the hybrid system, so we can do direct control after the surgery within our hybrid operating theater. But the patient alive, but still not in a good condition. I think it's very difficult with this situation to patient get a very good condition. Also, we find also some complication of the coil that ruptured. We have to take it out and put a clip for this kind of patient. So
Dr. Sudawidi, sorry, you have 3 minutes left.
Okay, it's enough.
Yeah.
Good. This is a shared competency. I think we have to know that our friend also have the competency level 4 for this kind of problem. And this is the education standard. It is fulfilled by law of Indonesia. And this is what we are going to be having for our young neurosurgeon. I think they have to know that as a specialist, we still have at the level of 3 for the aneurysm. When they have fellow, joining the fellow and get the certification, they will be able to do all the cases. And of course, when they have in the level of subspecialist for the simple, but for the complex aneurysm, I think surgery is still 3. But most of the difficult procedure in the intervention they can do after they join the fellow. Of course, finding is still the second challenge, and I think our society have tried to fulfill with this with the changes of the INA CBGs right now. And what about the facility? Cath lab has been all over Indonesia. There is no problem with this. Our cardiologists have helped us for this situation, but surgical, we have a standard operating theater. Of course, they have to be completed by microscope and microsurgery set, but there are some centers that developing the hybrid operating theater. Dr. Afan will talking about this. I think our hospital has been fulfilled with this kind of operating theater. And the fourth challenge, of course, national therapies. I challenge everybody to start talking about this. I think if you want to make our services in aneurysm surgery getting better, we have to sit together, start to collect our data registry, and side by side working together to make our nation become a good, to have a good data and put it in the peer-reviewed journal, international journal. This is my future, our future view. Every big city should have a neurovascular neurosurgeon in the near future. Yes, thank you very much. I think it's 15 minutes. Thank you, Mr. Chairman. Yeah.
Thank you, Dr. Satyawidi, for your very good presentations about the future challenge in our neurovascular services in Indonesia. We move to the next speaker. The second speaker will be Dr. Asra Al-Fauzi. Maybe, yeah, okay. This is his CV. He is now the staff of Department of Neurosurgery Erlangga University, Surabaya, Indonesia, and Chief of Neurovascular and Neuroendovascular Therapy Center, also in the same university and hospital. He will talk about the future of stem cell therapy in neurosurgery. Dr. Asra, you are already here now. You would like to present it live or by a recorded presentation?
Okay, I will present live, I think. It's better.
Okay, yes.
Okay.
Okay, Dr. Asra, you have also 50 minutes for your presentations. The time is yours now.
Okay, thank you, Dr. Krishna, and all the participants, my senior, professor, neurosurgeon, or other doctor that interesting in this session. And I will share my, my presentation. Okay, can you can you see, Dr. Krishna, my slide?
Yes, yes. The presentation is clear,
okay.
and your voice is also clear. Yeah.
Okay. Okay. Thank you. I think I will present maybe another aspect of the, maybe our future in in treatment of some neurosurgical disease. And of course, this stem cell therapy is still a big issue, and until now, the research is going on. So I just want you to know, and I give you some perspective about this kind of stem cell therapy and how is neurosurgeon should deal with this in the future. Okay, yes, I still remember that when I was student, my mentor, my teacher always say that, if we have some, some brain disease or some central nervous system disease, so it must be, very devastating. Some with no treatment, and many patients, we're going to the worst condition until die. So, so this is, this is the issue, that how stem cell could be, have some future to treat this some diseases. And yes, of course, I think we are already know in our practice that we are neurologists, neurosurgeon, neurorehabilitation doctor, always have this, facing this kind of, condition time by time in our daily practice. Permanent damage in the nervous systems after some disease, stroke, trauma, spinal cord injury, neurodegenerative disease, high-grade malignancy, cerebral palsy. I think we, until now, the recent scientific data showed that this all kind of disease sometimes have a brain damage, and no treatment yet until now. So I just want you to know about the theory of the stem cell therapy and how they, how the mechanism of action of this kind of therapy. Yes, first, the theory is replacement of injured or died neural cell. But now we call it a Parkinson effect. The stem cell, have some benefit to, have some neurotropic factors that that will be very agent to treat some diseases, and also the stem cell also can deliver some deficient factor, for example, for Parkinson disease. So it can deliver some gene or neurotransmitter to some area of the brain that with destroyed of some cell there. Many I think many physicians, many doctors always ask, how is the recent condition of cellular therapy, especially in central nervous disease? You can see here, actually many research have been done in the world, in many countries, to treat many kind of disease. You can see here about the stroke patient, cerebral palsy, and also interesting that in 2002, you can see here that they they have some research to do the autopsy in one patient with stroke, and they make some research, neuropathology research of the brain, and it showed a positive result that the stem cell that has been implanted is survived. But the problem is the no connection with the other area of the cell. So the functional improvement is so no benefit at all. But for neuropathology, showed that the stem cell is alive in that brain. So, and then, yeah, yes, this is the stroke treatment. You can, until now, thrombolytic therapy for acute stroke, yes, is available for relatively few patients because of narrow therapeutic windows and facility issues. So we already know that only 20% of the stroke patient can reach the golden period, golden time, and have this thrombolytic therapy with a better outcome. And also a large number of neuroprotective agent treatment have appeared promising only in the laboratory, but until now shown little or no useful at all clinically in the patient. I mean the stroke patient. So this is the problem until now. So we need some other, therapy with, no time limited, minimally invasive, and more available to many patients of stroke. So I think stem cell is one of the choices. This is the important philosophy of cell therapy: to replace the dead neuron or injured cell, or to stimulate or to have the Parkinson effect, to to increasing the neuroendogenesis in, we call it the adult neural stem cell or stem cell knees in subventricular zone or in subgranular zone, as you know. The recent theory of the brain. And yes, this is important. We have to know that the approach of the stroke therapy is very important. And I think as a neurosurgeon, yes, we have, capability. We have some, some part to, involve in this kind of treatment. You can see here direct transplantation intracerebrally, intraventricular transplantation, or maybe with endovascular treatment using the vessel to the brain. With each have some advantage, some different mechanism of action, and also have some outcome is very different. So I will not talk deeply about this, but stem cell source is also a big issue in our research today. Which is the source is the most, the most benefit to use in stem cell therapy from, from bone marrow, adipose, from, xenograft, from animal, from embryo, other things. Yeah. So this is still on research, and until now, the research so no data about the most superior ones using this each of the stem cell source. And so yes, in this time I will talk mostly about the stroke because in my hospital we have some experience treating patient. I've been the stroke patient with the stem cell therapy. You can see this from the slide, beneficial action of transplanted stem cell for each diseases. From stroke, you can see here, no the theory of cell replacement, but it's have some theory for anti-inflammatory effect and no neuroprotective effect, but the another is unknown. Yes. Neurotropic effect is unknown. So I just want you to know this. This is a report from Journal of Surgery in 2005 from Steinberg, as you know, from the Stanford University. This is study were for phase 2 with 18 patients. The subject is chronic basal ganglia. So this is chronic one. They use neuronal cell. I think it's from teratoma. I think the source, and the route is intraparenchymal. Presumed mechanism is more replacement therapy, not parking effect. So the outcome is improvement in treatment group, but no statistically different. There's some adverse effect were reported in this statistically different. Another from Korea is, I think, in 2005, a long time ago. It's also studied in phase 2, I think, in one single center, I think, in this hospital, 30 patients. The timing of intervention is the subacute large cortical infarction. So in the subacute phase, they use autologous bone marrow. The route is intravenous. So the presumed mechanism by this author is more the paracrine effect, despite the replacement theory. So the outcome, you can see here, the improvement in treatment group, but not statistically significant. They reported the adverse effect were known. You can see intravenous, known adverse effect, but the previous study with intracerebral or intracranial is some adverse effect happen. So this is our report, the first I think in 2016 from my hospital. Yes, I use the direct intraventricular transplantation. But you can see, I don't know here, you can see in the CT scan. This is a case report, but this is very interesting. You can see the infarction in the occipital area. You know, after several weeks after transplantation, there is a changes in occipital infarct area were clearly observed after transplantation, and also the perihematomal hypodensity area was reduced after transplantation. See, this is the patient in very persistent vegetative state, you know. So you know, in our hospital there is a rule that stem cell treatment indication is very strict. If you know the patient, you know, no value other treatment, you know, with persistent vegetative state, so we have to consult the family. There is another alternative therapy. We know that other therapies already failed. This is a chronic phase of stroke. I think after 6 months, I did the operation of intracerebral hemorrhage, but the patient is still in vegetative state. So yes, this is our research too, from the Open Neurology Journal. You can see here the 1-year follow-up of our patient there. Yeah, and the subject of my research is the chronic hemorrhagic stroke. 16 patients. We use the autologous bone marrow stem cell, and the route is a little bit different from other research that time. Mostly that time is intravenous, intraarterial, or maybe intrathecal, but I use the direct intraventricular. My presumed mechanism is the Parkinson effect, more than replacement. So the outcome is improvement in treatment group, but again, not statistically significant. Only one reported the adverse effect is transient severe cephalgia. We don't know why it's happened. We already take an MRI of the patient, CT scan, repeated CT, but we don't know what happened. It's clear on radiologic examination, but the cephalgia is, you know, is resolved after 1 week. This is another tool very important from India, you know.
Sorry, Dr. Asra.
Okay.
Sorry for interrupting. You have 3 minutes left.
3 minutes, okay.
Yeah.
This is another intravenous transplantation. You can see safe treatment, but there is no beneficial effect on stroke outcome. So the same. So the issue, the latest report from Lancet, you know, the safety and efficacy of stem cell therapy for ischemic stroke. You can see here the interpretation that stem cell therapy was safe and well tolerated, but still no significant improvement if comparison with the conservative treatment as usual. Yes. So for stroke is different from from Parkinson or for spinal cord injury because some critical issue in stroke, you know. Stroke destroy all the cells, you know. The neuron, endothelial. So which stem cell is very good to you know, restore all the cell. So the timing is very important. Acute, subacute, and chronic phase. Which is best time to treat our patient with stem cell? Yes. Mostly, you can see in the article that mostly research is in the chronic phase. Several arterial occlusion without collateral circulation. This is very important too. Yeah. Also, the various anatomical damage and various functional deficit. So, how stem cell can improve this? Still, we don't know. So this, okay, timing, still we don't know which the best time, and also direct implementation or systemic implementation, which is better. Some said that near or in situ implementation is better. So, you know, stem cell accumulated in that area in very high concentration. What specific damage, dosing and timing of transplantation, there is no clear guideline yet. Route and site of delivery, no clearly the protocol, source of stem cell, and how we conducted research, how to monitor the, you know, the stem cell. It's going to the that damaged area, or only a little that will going to that damaged area, we don't know. And yes, the conclusion is stem cell transplantation therapy for stroke hold the great promise. The beneficial effect of stem cell might include neuroprotection, angiogenesis, endogenous neurogenesis, modulation of inflammatory and immune response, and also the cell replacement, like in Parkinson. You know, the Parkinson is the cell that produces dopamine. However, many fundamental questions related to the optimal candidate, the best cell type, the number and concentration of cells, the timing of transplantation, the route and site of delivery, and adverse event monitoring need to be urgently determined. More research is needed to answer many questions regarding stem cell therapy for stroke. Collaboration between neuroscientists, neurologists, neurosurgeons, and other related physicians is required to translate cell transplantation therapy to the routine and safe clinical practice. So thank you very much. I hope it's, you know, it has some benefit for participants. Thank you very much for your attention. Thank you.
Yes, thank you very much, Dr. Asra, for your very nice presentations and lecture about stem cell therapy regarding our neurosurgical services. We have to move to the next speaker. The third speaker will be Dr. Afan Priambodo Permana from Jakarta, Indonesia. Dr. Afan, do you already joining us in this Zoom meeting?
Yes, thank you, Dr. Krishna.
Yeah, okay. So Dr. Afan is now staff of Department of Neurosurgery in Cipto Mangunkusumo Hospital, Jakarta. And he is also now the program secretary for neurosurgical program in Department of Neurosurgery in Cipto Mangunkusumo University of Indonesia, Jakarta. Dr. Afan will be talking about hybrid OT, needed or too much. Dr. Afan, you have 15 minutes as well. Time is yours now.
Dr. Krishna, I've already sent the video. I think I'm going to record one.
Okay, so please committee, can you play a pre-recorded video from Dr. Afan?
Okay. Good morning, good afternoon, good evening, everybody. Thank you for the committee to have to give me a chance for talking in the second Asian Congress of Neurological Surgeon. I'm Afan Priambodo Permana from Jakarta, from Cipto Mangunkusumo Hospital and Faculty of Medicine Universitas Indonesia. I try to talk about the hybrid operating theater in neurovascular surgery, needed or too much. I'm still a novice in this hybrid operating theater, but we already installed it in just last year. So I tried to explain why do we need it and how we build it. The idea of the hybrid operating theater is about 20 years ago, resulting of advance in medical technology. You know, these days the medical technology and medical technologies increase in the search of the popularity of the laparoscopic procedure for minimal invasive. So the core problem hybrid operating room solve is the ability to undertake several complicated surgical procedures without having to move the patient from room to room. And what is the hybrid operating theater? I don't need to explain much to all of you. This is open surgery. We already know about it. And image-guided procedure or endovascular surgery. Is it possible the MRI interoperatively, CT interoperatively, or angiography suite interoperative? So it should be can be both. The open surgery is called minimal invasive surgery or interventional. The left one is laparotomy procedure. The second one is laparoscopic procedures, and the last one is interventional. We cannot replace it, but we can not replace one to another, but interchangeable maybe for the best for the patient. So the core value is the best for the patient. What is hybrid OT? It's fully equipped surgical suite that facilitates collaborative and efficient patient care. It combines all components of cath lab and surgical OT, and the ideal setting of enable hybrid procedures to be done singly, sequentially, or concurrently. There's some potential benefit here. It facilitates interdisciplinary approach to care, may improve outcomes and safety. This is the most important one. Streamlines patient flow by eliminating patient transfer and staging. You know this, like Formula One when they're changing the tire, and then we serve fast, but we don't need to change it. In this, we don't need to transfer the patient. And increase access to care by expanding population for specific procedures. This right, and flexibility for future innovation and care delivery and procedures. The potential challenges is require cross specialty alignment. We need to talk more. We need to collaborate more between one to another, increase operational complexity, including staffing and training, and large capital investment. That's the point. The large capital investment, it's really, and we need to talk to the director or the one who give us the money. This is just all paradigm to the emerging paradigm. So we need to more collaborate between one and to another. And in our hospital, before we built this hybrid OT, we talked to many disciplines like cardiovascular, cardiothoracic surgeon, neurovascular surgeon, neurosurgeon, and interventional radiology, and vascular surgeon. We talk together. We try to find out what is the best hybrid OT for us. This is key step in building and operating a hybrid theater. I don't talk about the phase 1, phase 2, and phase 3. I mean, I don't talk about all, but I will just focus in phase 2. In phase 1, I will read it to you. It's planning, of course, institutional fit, financial analysis, planning team, vendor collaboration, site visits. Phase 2, design and construction, location and space, from design, table, imaging, audiovisual, and communication, and IT. We, as a user, as a neurosurgeon or natal interventional, we need to give a lot of concentration here. And the phase 3, it is just more managing, staffing and operation. We need the staffing, training, because it's across a platform, scheduling, protocols, hybrid OR committee, and inventory management. We'll talk about the phase 2. I will talk to you one by one. Location spaces, I don't need to read all of this, but it reached 600 to 1,000 square feet. It's about 60 to 90 meters square. So for accommodate people and equipment, to give more than 20 or 25 people in the operating procedures, let enough space for 2 teams or prep, and headroom is crucial. We need at least 10 feet clearance. Okay, this is the most important one. We need to find out if we have a places and location, we need to really understand about this. And it is very good if you're really close to the OR. The floor plan. For floor plan, we need a building of full scale kind of mock-up, and then we try to talk together and try to many different procedures how to because of for floor plan, because we don't want the anesthesia room it's a crash to the C arm or anything else. So this is very important. We talk about this, and we need to use the grid table. In our hospital, we use a Magnus table. We have a two floating, so it's a flat and floating, and a breakable one for the surgery if need the breakable one. And flat, floating, and breakable is interchangeable by a system, a very simple system. This is floor plan. This is designed hybrid OT. So you can see here, where's the table, where's the curve table, where's the anesthesia machine, and others. This is our hybrid operating theater. The left one is the vascular procedures. You can see here, the anesthesia machine is in the foot in the left foot. And then we put the microscope away first, and then after the microscope, we need to the microscope, and then we took the microscope there to the operating area, and then move the C-arm outside. We built with the Philips, the ceiling mounted one, and we talk a lot with them about 3 months. We prepare a lot of things with them. So this is really important for the phase 2. This is the progress, and this is the final. The ceiling plan. The ceiling plan is more important if you put the ceiling mounted C-arm. But if you floor mounted C-arm, maybe it's not a big deal. The ceiling plan, because the movement of the C-arm, you need to calculate they don't crash with the surgical lighting, monitor booms, cameras, and C-arm. Okay, of course, the C-arm. And then we have a laminar air flow ceiling. The laminar airflow for a flow ceiling is to prevent the infection in intraoperative area. So the laminar airflow, it's quite not a challenging for the ceiling mounted one, but not a problem with the floor mounted one. But both between the ceiling mounted and floor mounted vendor, they have their own paper. But in my hospital, we choose to use the ceiling mounted C-arm, and we already read about the paper, and so far we already have 20 to 25 surgery, and we don't have the surgical site infection there. But this is still up to you if you want to use the ceiling plan or the floor mounted. Imaging, of course, the latest technology will have a latest the latest technology will have a latest images, of course. And these days, the post-operating procedures like an program, we can have 3D images, 3D rotational angiography. We can do a CT even in the room. So we don't need another CT interoperative, but maybe next time MRI interoperative will be very important. But CT you can change by cone beam CT with the C-arm. The audiovisual communication is very good because everybody can see in every monitor inside the room. Okay, from the Vascular Guideline Institute, they make a guidelines for hybrid operating rooms. This is a space requirement, imaging equipment. Don't forget the radiation protection and dose reduction, and the workflow efficiency, flexible movement and of all equipment in hybrid OR, the acoustic consideration, and restricted environment, because you need to very restricted because there's radiation. And since it's hybrid between the cath lab and OR, so the culture should be mixed between both of it. Okay, this is surgical specialty that what kind of procedure can do by any person in hybrid OT, cardiovascular, cardiothoracic, neovascular, and others. I just want to show you that many discipline can work with this hybrid OT. This is the for the cardiovascular, vascular, or cardiothoracic surgeon, and the cardiologist. There's a TEVAR, there's a EVAR, there's a hybrid coronary artery vascularization, and anything else. They can do this in the hybrid OT. And the hybrid two-stage repair of the abdominal aortic aneurysm 2 is already published too. So how about us for a neurosurgeon or neurovascular or neurointerventional? The advantages of hybrid OT is enable the comprehensive microsurgical and endovascular management of neurovascular disorder in one facility, allow easy and immediate conversion to open microsurgical management under condition when the endovascular therapy is attempted but deemed unfeasible, facilitate combined endovascular or microsurgical approach to complex condition, support stage endovascular and microsurgical approaches, provide access to high quality gold standard intraoperative imaging to help document cure or guide additional targeted therapy. It's very important because these days the quality of the image is more and more great. It's become an awesome picture. Expedite the detection and immediate management of unrecognized intraoperative complication directly. Surgery, if you do open surgery, you can see if there's any problem with the vessels, if there's a thromboemboli or anything else. Dominance vascular surgery and vascular hybrid OT, Choi et al. Divided to 5 intraoperative angiographic evaluation for aneurysm, combined endovascular and surgical procedure for aneurysm and AVM, complementary rescue procedure of intervention surgery when clipping and rupture, coiling and rupture, and stroke ischemic, surgical approach for interventional procedures, and a frameless stereotactic operation since the system can guide you to do stereotactic, frameless stereotactic. This is I get it from the paper. The left one is there's a subdural and there's aneurysm. They did the coiling aneurysm and then they did the efficacy hematome. The right picture is AVM. They did emulation and directly to the resection. So this is really gold standard. This is another paper from the Chinese team, the working roadmap in neurosurgical hybrid angiosuit and development and practice of a neurosurgical hybrid angiosuit. More and more cases. Maybe in the future we will treat more and more cases and more satisfactory pictures because we can directly intervention the disease. And this is 4-year experience. They did clipping for some cases and then after coil, and then they can see everything inside the operating theater with a CT or with a angio. I have a case. This is a rupture aneurysm. Rupture previously clip and rupture after 10-year aneurysm in the right middle cerebral artery. You can see here, it's a huge hematome. We did angiography intraoperative before operation. You can see there's a huge and a big aneurysm. You can see there. And then we did a 3D. I'm sorry, I didn't put the 3D here. There's a M2, M3 aneurysm from the trifurcation of the middle cerebral artery. And what we did for this patient, we did the trapping first, trapping the aneurysm, and we cut the aneurysm. After that, we stitch it. Okay. And then the final angiography. The final angio, the quality is still good, but we have a pin here, so some of the images, some of the vessels cannot see here. After finish the procedures, we take out the pin, and then we did directly the CT, expert CT, so we can do anything in one stage, in just one hybrid operating theater without move the patients. The second case, there's you can see here there's a bump in the right, and already did a surgery by some surgeon outside our hospital, and then it grows. This is from the left one. You can see here from the ICA, there's nothing. But from the ECA, the external carotid artery, you can see here from the artery of foramen rotundum and the middle meningeal artery, there is a fistule, AV fistule, and then it grows and make the vein and lymphatic problem here. So what would you choose for this patient? We did the embolization first, and then we go directly to surgery. We disconnect we open the visual superior, and then we take out the atriocondylar process, and we open the optic foramen, and we disconnect all the vessels from the cranial to the orbit. I think I don't need to show you this. And then the last one, this is the images. There is no more vessels, even from the internal carotid artery and an external carotid artery go to the orbit. So we cured it directly. We see it directly, and there's no more problem with this patient. But we cannot save the eyes. So as a conclusion, the hybrid OT is important for top-tier hospital with multidisciplinary team, at least one in area or city or in province. Since our house is a public government hospital, so it is important to have this. And it's very high cost. And you need to talk to the director from the hospital, and should consider multifunction by multidiscipline. So we can work together, the hybrid OT, not just for the OT, but for the angio too. And then cardiovascular cardiologists work there, the vascular surgeon can work there, and the cardiothoracic surgeon work there, and anybody can use this facility. So it will be the utilization will be so high. And for the neurovascular team, this is necessary and challenging, and we can help more and more patients for the patient safety. Thank you very much for your attention. Thank you, the committee. Thank you very much.
Yeah, thank you, Dr. Afan, for very nice and very inspiring. Yes. Okay, actually, you have one more topics to be explained, but according to the schedule, it will be delivered on the last sessions of this session. So we move to the next speaker, and the next speaker will be Dr. Tondi Maspiancili, and he will talk about the highlights on our new neuroendovascular surgery service in Riau province. Dr. Tondi is a neurosurgeon in the Department of Neurosurgeon at Dr. Arifin Ahmad Hospital, Indonesia. And he finished his neurosurgical specialty in 2005. Dr. Tondi, are you already with us? Dr. Tondi? Do you prefer to present it live or by recorded video?
Okay, thank you, Dr. Krishna.
Yes.
Because the time is limited, can you play the video that I have prepared?
Okay. Yeah. Okay, please, committee, can you help us playing pre-recorded video that has been sent by Dr. Tondi?
Assalamualaikum warahmatullahi wabarakatuh. Thank you to moderator, the honorable to the committee, professors, and colleagues for the opportunity that has been given to me to present about the state of neurosurgery services where I work in this very honorable meeting. Okay, I will start to explain through my first slide. The title that I present is a highlight on our neuroendovascular surgery service in Riau province. So I work in surgery department and neurosurgery subdivision in general Arifin Ahmad General Hospital, School of Medicine, Rio University. This is my abstracts. The purpose of this paper is to explain about the geography, demography, neuroendovascular services in Rio province. Neuroendovascular services need to the preparation of facility, infrastructure, and human resources. Neuroendovascular services that have been carried out include diagnostic for as many as 73 cases, neurointervention 17 cases in the form of coiling, tumor embolization, CCF ballooning, and pipelines. The biggest difficulty in the providing the neuro intervention services is financing for the consumables. Cross-sectoral cooperation is needed to finance the procurement of consumable with the local government and include forming a non-profit organization like Nero Foundation to accommodate donation for financing consumables. Need support from professional association of neurosurgery in terms of providing competency certification for the neuroendovascular services is keyword neuroendovascular, neurointervention, financing, and corporation. Okay, the geography, Rio Province is located in the middle of Sumatra Islands. The north, it is bordered by North Sumatra Province, the south by Jambi Province, and the west by West Sumatra Province, the east by the Riau Archipelago Province, which lead to the border with neighboring Malaysia and Singapore, is separated by the Strait of Malacca. The area of Riau province is about 87,000 kilometers square, which consists of 12 regency or cities, with the provincial capital being in Pekanbaru City. This is the map of the Sumatra Island, and this is Riau provinces. This is at the north of the Sumatra province with capital of city is Medan, and this is at the west with West Sumatra province, the capital province in city in Padang, and in the south with the Jambi province with capital city is Jambi, and also we neighboring with Malaysia and Singapore is separated by Strait of Malacca. So this is a map of the Riau province. It's very large province area to cover this. The total population of Riau province is about 7 million people, and about 51% is male, with about the 16 residing in the provincial capital, which occupies an area and only 1.73% of the total area Riau province. Life expectancy about 71 years old, and the percentage of population that has health insurance by BPJS and Jamkesda is about 61%, and private and corporate insurance is about 4%, and 34% do not have health insurance like this is data from BPS Rio Province at 2019. By looking the data, this data, it's clear that the distribution of population is not evenly distributed, which will make it difficult for health services, especially for the referral system. With the high life expectancy, it can be estimated that the disease pattern will shift from an infectious disease pattern to a degenerative disease pattern. Neurosurgery services in Rio province began in 2000 with the placement of a neurosurgeon. And now there are 9 neurosurgery specialists. The neurosurgical services performed include like neurotrauma, neuropediatrics, especially congenital disorder, neuro-oncology, and degenerative, neurospine, and neurovascular, especially for open surgery. In 2019, we had opportunity to take part in neuroendovascular training at the neurosurgery department of Sutomo Hospital and Faculty of Medicine Erlangga University in Surabaya for 6 months. This training covers at one, the basic of operating and setting up fluoroscopy equipment, and second, introduction to basic techniques of the neuroendovascular diagnostic and neurointervention. In 2020, we prepared the facilities and infrastructures available at the hospital where we practice, including preparing human resources so that neuroendovascular services can run. The first time we did the endovascular service, we continue to be observed and survived by our teacher from Surabaya until we felt it was appropriate to carry out diagnostic and neurointervention measures. The diagnostic measures in the form of DSR as many as 73 cases. Vascular abnormality as many as 39 cases. The vascular abnormalities were aneurysm, AVM, carotid cavernous fistula, blast tumor, stenosis, and epidural fistula. This is the abnormality we found after the DSA. The vascular abnormality found with the SA as many as 17 cases were followed by with intervention. The first is coiling, embolization, carotid cavernous fistula ballooning, and pipeline of flow diverters. The delay in follow-up is due to financing for the consumable is not covered by BPJS financings, and the patient dies soon after the diagnosis is made. And the third, the financing is generally patient. This is the problem in our area, in our hospital. So many patient is delayed to perform the neurointervention. This is, for example, we found at the DSA, so that we saw that this is like aneurysm at the basilar tip. Aneurysm is a lot, and then we do the coiling for this patient. Okay, this is the coiling was performed to the basilar tip aneurysm. It's the first case for me to perform the coiling and supervised by my teacher in Surabaya. And this is, we found we saw that the blast of tumor, and then we perform embolization for this patient. So this is look at the blast tumor is reduced is for the next surgery. Is tumor embolization. And then, for example, we do the ballooning CCF. We found that patient with CCF, this is a huge ophthalmic vein, and then we perform ballooning for this patient and reduce of the ophthalmic pain. But I think it's have the still have the fistula, and we will perform the second ballooning next. And this is the case with aneurysm at the right vertebral artery. Yeah. So it's very wide neck, and we plan to perform the pipeline of flow diverter is we have done. So it's like this. Yeah, this is have done the flow diverter for these patients. Follow up the actions taken to overcome these difficulties. The first, hearing with local official to make budgeted assistance costs through the APBD, and the second, perform a non-profit organization like Neuro Foundation that accommodate donation from the various elements to be used to purpose consumables. And the third, using the consumables that are already available in the e-catalogs. This is will do to the neurointervention consumables. And this is our conclusion. It is necessary to increase the number of places and number of trainings opportunities for the neurosurgeon so that neuroendovascular services are increasing available. Urgent need for the bureaucratic reform to Neurosurgical Association in granting competency certification for neuroendovascular services. Need to change the nomenclature of neuroendovascular measure in BPGS. Strive for cross-sectoral collaborations and the formation of a not-for-profit organization to assist the cost of the consumable. Just my short presentations. Hopefully it can provide useful information in the development of neurosurgery services in Indonesia, especially for area that will start neuroendovascular services in their place. Thank you very much. And Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Tondi, for your sharp 15 minutes presentations. Very good highlighted conclusion remark you have, and it's also amazing that you can do such complex neurovascular case even outside Java Island. We are running out of time, and it is now for the last speaker. We are going back to Dr. Avan Priambodo, which will be delivering code stroke protocol in Rumah Sakit Cipto Mangunkusumo or Cipto Mangunkusumo Hospital, Jakarta. And he will be delivered these presentations by the pre-recorded video. So please, for the committee, can you help us to play his video? And he also informing us that you can play it starting from the minutes 2.
Yeah, thank you, Dr. Chris. Committee, please start with minutes 2. Minute 0.
Okay,
zero,
sir.
zero. Yes, because we don't need to explain again about.
We are still setting it up.
Okay. Yes, you can try. You can start from here. Thank you very much.
Thank you.
Okay, we can proceed it now.
I think there's no sound yet.
Delayed in the management of the acute ischemic stroke patient. So we need to have a more campaign to talk to the government, to the public, and to all the people, to especially for the bystander and the person itself, and especially for us as a neurosurgeon, neurologist, and medical doctor, GP. So we will get more awareness for the stroke, because you understand about this damaged brain. And this is the ADS stroke system. This is we talk about that there is an ADS stroke system. There's a detection, dispatch, delivery for pre-hospital, and inter-hospital. There's a door data, decision diagnosis, drug device, and disposition. We published about this recommendation of AD stroke system for emergent acute ischemic stroke, a literature review. Me, myself, and my colleagues as a writer. And we talk about the pre-hospital first. Since we're going to talk about code stroke protocol in our hospital, in my hospital, then we talk about the pre-hospital first. Detection, dispatch, and delivery is the pre-hospital approach. So we need to increase awareness for detection by a more campaign about the BFAS, balance, IFAS, arm speech, and time. This is really important, because from the onset to the hospital is really important. On this stage, we need to create a system by ambulance or emergency call. So dispatch, this is type of disease will go to which hospital. And the most important one too is delivery. The ambulance will the ambulance or the patient itself, the bystander will bring the patient to where? Then we need to stratify the hospital. The ACNS already make a stratification about the basic care hospital, like acute stroke ready hospital, primary stroke center, and comprehensive stroke center. And in 2018, they built a thrombectomy capable stroke centers. So this is important because since we understand about the transfer, there will be a drip and shift versus partnership for endovascular treatment. It's already have a result. So we still need to make a system about this delivery. In Jakarta, as I know, there's a 3 hospital that already became a comprehensive stroke center. Yeah, in Cipto Mangunkusumo Hospital, National Brain Center, and Army Hospital, Dr. Subrata Army Hospital. So in the next, the pre-hospital really need to increase because since time is brain, and from the onset to the management, it's really the windows is very short. And the government, Indonesian government, already make this. The government already make a campaign for a lot of peoples. But I think we need more campaigns so people will understand the system will establish like a trauma or establish like a primary acute coronary syndrome, like a heart attack. So we need to campaign more about maybe brain attack, something like that. Okay, now we talk about the acute stroke protocol in my hospital in ER. So we talk about we discuss multidisciplinary. You can see here. In the left one, there's a 3 big group. Like first is the ER. We have an emergency medical officer and residents, and we have administration and a nurse, and we have a acute stroke team. There inside there'll be emergency physician, and then there will be a neurologist, and then neuroradiologist, and a neurointervention, and then neurosurgeon. So we discuss together, and we try to make this as our goal. We divided time limit, time target from 0 to 60 minutes. We will discuss about it later, step by step, like this, from 0 to 10 minutes. We make a priority is triage, stroke activation, patient registration, neurological exam, and transfer to CT preparation. So the most important thing is patient identification and onset. Time lapse non-well, time lapse in well, and wake-up stroke. And we will do a very fast primary survey and initial assessment. And after that, the emergency medical officer or neurological or nurse will activate acute stroke. So we will do, the highlight is fast neurological exam and do POCT glucose, just glucose, not other laboratory, because a lot of other laboratory you can take it, but do not delay CT. A CT brain preparation, and then since our insurance, we need a coding system, so we will talk directly to the emergency medical manager or management on duty at that night. And the ECG and thorax, you can do it, but not delay a CT. Okay, and then the next time is triage, vital sign exam, oxygenation, ECG, and preparation for transfer to CT. This is what we do in the first 10 minutes. Okay, next. This is the fast screening and examination in ER. We got an onset, and IHSS, POCT glucose, and ECG, and we calculate. We based on this world standard for time response. Door to CT should be less than 20 minutes. Door to needle for thrombolysis less than 90 minutes, and door to groin puncture should be less than 90 minutes. So, and in 10 and 20 minutes, since about the time response, we should do the CT as soon as possible. So, complete hospital taking by preparing the CT, maintain blood pressure less than 185 per 110. Result of CT for decision, inclusion and exclusion criteria for thrombolysis and management of the patient. Don't forget, After that, in this era of COVID, we did directly the antigen swab and PCR for in the Gen Expert system. So we already know about the COVID status of this patient. So transfer to the patient to the red zone in ER. Spatial, we have a spatial red zone in ER. So people manage all the system will concentrate with that red zone. Directly the IV line, 2-line large bore, and blood samples. Inside the CT, if the CT is a hemorrhage, continue to hemorrhage stroke guideline. If the ischemic stroke, need for the exam, then with the large dead bore, we have we put a 2-line large bore. One is for the thrombolysis, and the other one is for the angio. We need to understand the large vessel occlusion as soon as possible. Okay, this is the data, the ischemic or hemorrhagic, the aspect score, and the signs of LVO, the signs of LVO. We talk about the signs of LVO because clinically we can diagnose with an NIH stroke scale, but radiologically, objectively, we need to get the imaging by neuroradiologists. Now, 20 and 60 minutes, still a minute of the vital sign and clinical symptoms, interpretation or laboratory result in ECG, record history, preparation for thrombolysis, inform the cath lab for possible thrombectomy, and prepare for thrombectomy. If we already know about if there is any large vessel occlusion for facility angio, and maintain blood glucose. For the IV thrombolysis, you can see here, in the first minutes, the dose is 0.6 to 0.9, but we use the lowest dose in our hospital, 0.6, in bolus in 1 minute and 1 hour for 90 minutes. You can see here, less than 3 hours, the number needed to treat is 10. So it's quite good. And more hours we late, the number needed of treat will increase. The best number needed to treat is 1. So if we help people, we give that medicine comparing to control number needed to treat, it means you help 1 people if you help the people with the medicine. So this the 3 hours window is very short comparing that our city, Jakarta, our city, Jakarta is very crowded city, so there will be a traffic, something like that. So we need to reduce this time. And then we have the stroke kit, so Angels Initiative. You know the Angels Initiative, right? We have the stroke kit. This is neurologic. Our neurological system already built this, and then we put this in ER, so everybody can take it directly from the if there's a stroke system, if there is stroke patient. And still in 20 to 60 minutes, we monitor preparation pump as equivalent. So we prepare we give the thrombolysis as soon as possible after it's equal the criteria, and we transfer the patient as soon as possible if eligible for thrombectomy. And we set the treatment based on onset. We divide it with less than 0.5 hours, 5 to 0.5 hours to 6 hours, beyond 6 hours until 24 hours. It depends on onset, the NIH stroke scale, and the CT brain. Okay. There's a for thrombectomy. If a suspected LVO, we should meet the criteria with a 1A level. And this is with I level for 6 to 16 hours and 2 ABR for 16 to 24 hours. But for before 6 hours, there's thrombectomy is a real 1A recommendation. But meet the criteria. Pre-stroke MRS should be 0 to 1. Cause of occlusion should be IC or M1 or large vessel occlusion. Age more than 18 years old, and eye sex is more than 6 with aspect score more than 6. This is we still doing this, the AHAC 2018 recommendation for our guidelines for the thrombectomy and management of stroke in our hospital. So, but there's a suspected LVO from clinical diagnosis. So our cutoff is a 6, but you can see here. According to the this is one recommendation. According to the meta-analysis, threshold more than 10 will provide the optimal balance between sensitivity and specificity. But if we use if you use more than 6, the sensitivity will be 87% increase, but specificity will decrease. But don't forget, even though the NIH stroke scale is less than 6, some of the cases is missed with the NIH stroke scale. So some people, some hospital scoring using using a diagnosed LVO with a lot of stroke scale these days. But the gold standards for understanding the large vessel occlusion is angiography. Either it's non-invasive like a CT or MRI, or directly to the now it's really popular about direct to angio. So we'll understand about the where is the large vessel occlusion. For preparing thrombectomy in our hospital, first patient should be eligible for thrombectomy. To inform consent the patient, consult the anesthesia. We need to go to the coding for the insurance, to the management on duty, inform the cath lab administration, and prepare the transfer of the patient to cath lab. This is our in a CBG's procedure for coding, and this is our the right one. This is our consultation to the cath lab, so they understand what will do. That the patient with a stroke will go to the angiography and prepare for thrombectomy. So this is our standard protocol in our hospital. The standard interventional thrombectomy protocol leads to faster recanalization times. So if you and your colleagues in your hospital talk about this, discuss together about how to make a system to management of stroke, you can see here the door to CT from the pre-implementation and post-implementation decrease from 16 minutes to 12.5 minutes with p-value less than 0.00, with p-value 0.004, and door off hours. Okay, this is normal, and in off hours is decreased to 17 to 13. But the most important thing is the puncture to recanalization or the CT to puncture. Say everything is decreased, but still in off hours, the response time is still longer than that. And how about the devices? The devices, then we need to standardize this device, involving mechanical thrombectomy time metrics and angiography stroke chart. So we prepare the devices too in our cath lab, like this in this paper. They make their own place for put all the devices for thrombectomy. This is available thrombectomy kit in our hospital, and I think I don't know. I'm not comparing to other hospitals. Still, we are left behind, but most all of the devices for the thrombectomy, either sternal retriever device or aspiration device, and all the supportive catheter, we already quite complete in our hospital. And we since we work together in the cardiologist cath lab, so we can do coronary angiography, and we have a stand for the if there's a tandem occlusion, so we can manage both tandem occlusion by angioplasty or stand the carotid and go to the internal vessels. So we need, if you want to have a great team in your hospital, you need to tell this detail. You talk to the vendor, and then they put all the devices in your hospital. So you don't need to wait for devices. Maybe for people from outside of Indonesia, we still struggle for put our consign our the devices in our hospital. This is the checklist for patient preparation, and me myself make a video for understanding, so the everybody can watch the video, and then this is the checklist for diagnostic. This is quite a long data, but you know the mechanical thrombectomy is now increased and it help more and more people these days. And this is this is my last slide, and this is already, you know, here you can see that from 3 months to 5 years, from 3 months to 5 years, sustaining long-term benefit of endovascular therapy of ischemic stroke. So it divided from patient factors, medical care, post-acute care and acute care, psychosocial factors and high-level factors. And still, we got quite a good result, but still we need to have a more struggle to improve all the system and finally make an improvement of the patient too. So I like from this 3 months to 5 years sustaining long-term benefit of endovascular therapy for the ischemic stroke journal, because they said that the race from stroke onset to EVT is a sprint. So it should be very fast from the onset to the EVT to the endovascular therapy. But for maintenance, EVT benefits from 3 months to 5 years is a marathon. So still, this disease, acute ischemic stroke, it's still our enemy, and we need to face it with a good system, good management system, and then we face it directly, and we should maintain the sprint and the marathon run. Thank you very much. This is my last slide presentation. Thank you for the committee for this for the time. So the cold stroke team should be comprehensive and multidisciplinary, and we need to work together side by side to defeat this kind of disease. Thank you very much.
Okay, thank you, Dr. Afan, for another inspiring lecture about the cold stroke in Jakarta. Okay, I think there is no questions popped up on the chat box, and I don't think there is also a question from the participant, if any, because we already 5 minutes late. Okay, if there is no question, I give the time back to the host, and maybe we shall continue to the next sessions. We still have more vascular satellite symposiums. Thank you. I am very sorry if I made many mistakes for moderating these sessions. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Welcome.
Waalaikumsalam.
Thank you for your great presentation. Thank you all speakers. Thank you all participants. Before we end the sessions, we are going to take some photos and take some picture. Please open the camera. Okay. On my mark. 1, 2, 3. Once again. 1, 2, 3. Okay, thank you very much. See you later.
Thank you.
Thank you, Dr. Krishna.
Thank you, Doc.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Dear all speakers and all participants, now we are going to third satellite sessions in vascular session 3. Pardon me, Dr. Afan Priambode is still here?
Yeah, thank you, committee.
Well,
can you hear my voice?
Yeah. Yes, yes,
okay,
Doc.
thank you.
Clear.
Okay.
Okay. Before we start the presentation, let me introduce our moderator now. He is Afan Priambodo Permana. He is neurosurgeon of Department of Surgery in Udayana University, Bali, Indonesia.
I think this is wrong.
And
I think this is not mine. I think it's okay, committee. I come from Jakarta.
Well, Doc, time is yours.
Okay. Yeah, okay, thank you very much. Dear colleagues and friend, professor, doctors, and all of the participants, the committee, thank you very much for today. Chance for me to lead the last or third vascular session. This is, I don't need to explain myself, of course, because today we will have a three talk from. Can you show me the Dr. Iwan CV? It will be Dr. Iwan Nur Setiawan Suroto, Dr. Adi Guno, and the other one come from India. Maybe I will talk about them later. I know Dr. Nur Iwan and Dr. Adi Guno. Dr. Iwan is the Chief Division of Endovascular Neurosurgery from Department of Neurosurgery, Sutomo Academic General Hospital. This is my teacher, my colleague, my friends. We spend together sometimes in South Korea, but we don't meet. I don't need to explain more about Dr. Nur Setiawan Suroto, or we can call it Dr. Iwan. Dr. Iwan, maybe you can directly present about your experience in 5 years about the carotid cavernous fistula from the transarterial embolization. The time is yours. You can start now. Thank you.
Thank you, Dr. Afan.
Yep.
The committee, I think I already sent my video to you, and you can just play it. Thank you. Thank you.
Hello?
Belum.
Wait a minute, sir.
Dr. Adi Guno. I think the first one is Dr. Iwan from waiting for the committee to prepare the video, the pre-recorded one. The committee, are you still in progress? Hello?
Pardon me, sir. Maybe we're going to next presentation. We still find the material of.
Okay, so do you mean we can? We should proceed to the second speaker.
Yes, sir.
Okay, Dr. Iwan, is it okay? I plan to go to Dr. Adi Guno first. Dr. Iwan.
Okay, no problem.
Okay.
Okay.
Committee, please
Thank you, sir.
Find the video that we sent by Dr. Iwan. Dr. Adi Guno, are you there? Dr. Adi Guno. Dr. Adigono? Okay, maybe do we have another speaker? Because it sounds to me, committee, maybe you can take lead first.
Yes, sir.
Maybe you can take lead because I cannot get the Dr. Adigono yet.
Well, we are to contact him.
How about Mr. Kevin Kadivani? Is it he will talk here too?
Hello, Dr. Kevin, are you ready? Still trouble here.
Okay, maybe I can give to you first, committee. So after you're ready, and then we can, and maybe you can talk to me later. Okay.
I am ready. I'm ready. We can go ahead.
Ah, I'm ready, Dr. Kevin.
Okay.
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 Yeah.
So is it okay? You proceed first. Is it okay?
No problem. I'm ready.
No problem. Okay.
Good afternoon.
Okay. Since I don't have your curriculum vitae, so we can proceed because the first two speaker there's some technical problem. So there will be a microsurgical outcome of brain AVM, our experience from Dr. Kevin K. Divani, maybe from instance name from India. I think this is the time is yours. You can start your presentation now.
Definitely. Thank you. Good evening, everyone, and I thank you for this opportunity. Committee, could you please play my pre-recorded video?
Committee?
No. It's the other one, actually. Hello.
We're still waiting for them, Dr. Kevin.
Yeah, actually, I sent another link of the pre-recorded video.
Wait a minute.
Yeah.
Good afternoon. I'm sorry. Dr. Kevin, we have a three video from you. Which one, if you want to play? Because under the topic is different with the schedule.
Sorry, could you please come again?
According to your video,
yeah,
is it different with the with our schedule? We have a three video. First, AVM. The second is GCS versus AEE, and the third is spinal and tumor.
Oh, the one with arteriovenous malformation. AVM.
AVM. Okay. Sorry for the trouble. Please waiting for one and over to until 2 minutes.
No problem.
Thank you.
Thank you. Yes, this is it. Goes directly into the draining veins without the normal interposed capillary beds. So there's a feeder arteries, there is a nidus, and there's a draining channel. They have a unique anatomy and a unique hemodynamic physiology, and they have the most complex pathology. Radiologically, they have a heterogeneous angio architecture, and embryologically, they have a mysterious origin, and the presentation is very latent, and natural causes unpredictable. They account for 1 to 2% of all strokes and fatality of 1 to 1.5% annually. Overall risk of rupture is 2.3% per year over 10 years, and rupture rate for unruptured AVM is 1.3%, which increases to 4.8% after it ruptures. It presents as in an unruptured form in the form of seizure, chronic headache, persistent and progressive neurological deficits, and also gets ruptured and presents as hemorrhage and along with its presentations. About 1/5 are discovered incidentally in asymptomatic individuals. DSA is the gold standard investigation to confirm the presence of an AVM and also to study its anatomy. We can study intranodal aneurysms, superficial or deep venous drainage, venous outflow obstruction, and the location of AVM. There are several gradings which are designed to help to guide treatment decisions. One of them, the age-old didactic Spletzer-Martin AVM grading scale, other ones being Spletzer-Ponce and Lawton-Young grading scales. Spletzer-Martin AVM grading scale grades the AVM based on the size, location, and deep venous drainage of the AVM. However, Spletzer and Ponce together made a 3-tier classification for cerebral AVM, which eliminates the 2 redundant tiers from Spletzer-Martin grading and has similar management strategies and similar outcomes and provides a simple treatment algorithm. The treatment aim of AVM is to decrease the risk of bleeding. The options which we have in our armamentarium are microsurgical excision, stereotactic radiosurgery, embolization, and combination and observation of these. Microsurgery has an advantage of its long-term durability and complete obliteration of AVM and immediate elimination of hemorrhagic risk. However, it's invasive and can cause neurological deficits. Radiosurgery, no surgery is required, and it is very useful for deep-seated lesions, and it is comparatively less morbid. However, it can induce necrosis, edema, and cyst formation, and the risk of hemorrhage during the latent period persists. Embolization has the advantage of diminishing the size of AVM, and the reduction of flow is observed. However, the disadvantage being rupture and recurrence risks are always persistent. The one who undergoes embolization should undergo microsurgical excision ideally. And the superiority of microsurgery as a treatment modality is reiterated in all the studies. So surgery in our institute is a mainstay of treatment for Spletzer-Martin grade 1 and 2, and for few of the patient with grade 3. Radiosurgery and embolization are adjuncts to the main surgery. So we have in some of the patient in like this with main feeders from left superior and inferior division of MCA along with left PCA, we would prefer observation, just simple observation. We use CT angio, MR angio, and digital subtraction angiography for diagnosing AVM in our patients. As an adjunct, in some of the patients, we use neuronavigation and functional MRI, diffusion tensor imaging, stereotaxic assisted craniotomy, and 3D models of AVM. Intraoperatively, we prefer the use of indocyanine green dyes to confirm the presence and obliteration of AVM. Intraoperative Doppler is a very useful adjunct to confirm the amount of feeders and also to make sure that we have obliterated all the feeders. The same fact is very beautifully reiterated in these videos. The microsurgery is the main form of treatment, and its basic tenets are wide craniotomy, wide dural opening, and very cautious dural opening because we can encounter feeders to nidus from the dura. The nidus is heterogeneous. Usually, we have to identify the borders of the nidus before excising. After that, we have to take a control of artery before the veins, Also, we have to clip accessible aneurysms in the nidus. And while dissecting the nidus, we have to work in the sulci and fissure whenever possible. The surrounding uninvolved arteries to the normal parenchyma should be preserved. The nidus should be dissected thoroughly on all sides, taking care not to spare any of it. The complications which we have encountered are direct surgical lesion over the eloquent area, post-operative rebleeding, post-operative seizures, and normal perfusion breakthrough. Direct damage to the operative bed can occur, which can be prevented by stereotactic radiosurgery, functional MRI, and DTI. During microsurgery, precise vascular